Today we will be examining a case of thyroid cancer and a patient along her cancer journey. The patient. Our patient's name is Amy. She is 43 years old and works as a school teacher. She is of Chinese descent and migrated to Canada as a teenager. She is fluent in both Mandarin and English. She has a 21-year-old son who lives 1 hour away at school. Her husband unexpectedly passed away from a heart attack 2 years ago, and Amy continues to struggle with her grief. She has recently been diagnosed with depression after her son noticed she was struggling and made an appointment with her primary physician. Amy and her son came in today after she was complaining of difficulty swallowing for the past 4 months. Amy also noted that she has been unable to wear shirts with a tight-fitted neck as it has been very uncomfortable for her. Amy stated that she didn't think much of it at first, but it has progressively gotten worse over time. When her son came home for a weekend, he noticed that her neck looked very swollen and different since the last time he saw her. Amy mentioned the swallowing difficulties, which prompted them to come in for an assessment today. The nurse asked Amy a few questions and discovered that she has also been occasionally short of breath during rest and has had a loss of 8 pounds since her last annual physical 10 months ago. On assessment, the nurse notes a painless mass noted on palpation and examination of Amy's neck. When Amy looks up or swallows, the mass is clearly visible to the eye. Amy's labs have come back indicating her TSH and T4 are within normal range. On further examination of Amy's health history, the nurse discovers her mother had thyroid cancer. Amy is currently taking sertraline to manage her depression. The nurse also discovers that Amy has been having a difficult time living alone and finds it overwhelming and exhausting to keep up with household tasks by herself.
Starting with the cancer site, I'm going to be talking about what thyroid cancer is briefly. Thyroid cancer is a type of cancer that originates in the thyroid gland, which is our small butterfly-shaped organ located in the neck, just below our Adam's apple. This cancer occurs when cells in the thyroid gland undergo abnormal growth and form tumors. The thyroid gland plays a crucial role in producing hormones that regulate metabolism, making the thyroid and thyroid cancer significant in its impact on our overall health. Thyroid cancer is relatively rare compared to other types of cancers, and its prognosis is often favorable. So, people that often are diagnosed with thyroid cancer, the prognosis is usually pretty well, and even better when it's diagnosed early and treated at an early stage. Now, diving into epidemiology, thyroid cancer is the 13th ranked cancer in Canada for incidence for both women and men this year, with 6,300 cases. In terms of mortality, it is ranked 21st with 270 deaths this year. The trend in terms of incidence for both sexes is decreasing, and in terms of mortality, there is no change. And the 5-year survival rate is 97%, so it has a really good survival rate compared to many cancers. It is also 3 times more common, or more than 2/3 of the cases are women, and many women are diagnosed with thyroid cancer within their late 40s and within that stage of life. Moving on to prevention of thyroid cancer, although it is hard to detect early, there are some things you can do to prevent thyroid cancer, and I'll also be discussing the risk factors associated with thyroid cancer as well. Some of the risk factors that are non-modifiable include sex and age. As I said previously, women are more prone to getting thyroid cancer, and it is more common in the later stage of life, within the 40s. Exposure to radiation is another risk factor, which is modifiable. Reducing the amount of radiation you're exposed to, such as dentist visits, x-rays, anything like that, can reduce the risk of thyroid cancer. Non-cancerous conditions of the thyroid are also another risk. So any other conditions with the thyroid, such as a goiter or nodules, can contribute to, again, increasing that risk for thyroid cancer. Another big one is a family history. and or hereditary conditions of the thyroid. So any family history of thyroid cancer elevates the risk, as well as multiple endocrine neoplasia type 2 and familial adenomatous polyposis, abbreviation FAP, is also associated with specific types of thyroid cancer. Obesity as well, and having a low iodine diet and diabetes have also been linked to thyroid cancer. Being tall and acromegaly are also risk factors for thyroid cancer. Screening for thyroid cancer. As for routine screening, that is not something that is done for thyroid cancer. I know, like for breast cancer and other types of cancers, there are routine screenings that can be done to prevent the cancer, but for thyroid cancer, there is not anything. But it could be detected while routinely visiting your doctors for a physical exam. So upon physical examination of the thyroid or the neck, any abnormal lumps or abnormal enlargement of the thyroid can be detected, as well as surgeries that are done for other medical conditions or reasons. Thyroid cancer can be detected, and with an ultrasound, that is also for another medical reason. That's how thyroid cancer can be screened for, but again, there are no routine screenings that are done for thyroid cancer. The nurse plays a very big role and carries a lot of hats when it comes to the diagnosis and the process of cancer and cancer treatment. It's important for nurses to provide education. In Amy's case, to provide the education about the genetic factors, genetic risks, as her mother has had thyroid cancer. So providing the education about the genetic risk that she has of having thyroid cancer. It's also the nurse's role to promote health, so a healthy lifestyle, healthy diet, and provide her with any information regarding to diet and a healthy lifestyle to reduce the risk of her thyroid cancer getting worse or her overall health getting worse, as well as emotional support. The nurse, after assessing and speaking to Amy, knows that Amy suffers with depression, so this can be a very heavy topic, getting diagnosed with cancer, and there's a lot of emotional support required. So giving Amy that support she needs or the resources she needs to get that support is also the nurse's role.
Okay, now we will be discussing the biology of thyroid cancer. So a brief overview of thyroid ANP. So the thyroid gland is located in the neck, anterior to the trachea and inferior to the larynx. It consists of two lobes that are connected by a medial region called the isthmus. The thyroid gland houses parathyroid glands, which are embedded in each lobe. The thyroid tissue is primarily composed of thyroid follicles, and thyroid follicles are functional units of the thyroid gland, which are composed of follicular cells that produce thyroid hormones. So the thyroid hormones are T3 and T4. Follicles contain a central cavity that contains a fluid called choroid. So this is the location of thyroid hormone production, and thyroid hormone production depends on iodine. Okay, regulation of thyroid hormones. So regulation is through a negative feedback loop. So for T3 and T4 regulation, low levels of T3 and T4 would stimulate the hypothalamus to secrete thyrotropin-releasing hormone, also known as TRH, which then stimulates the anterior pituitary gland to secrete TSH, which finally stimulates the thyroid gland to secrete T3 and T4. Thyroid hormone functions. So T3 and T4 functions include regulation of BMR, regulation of temperature, regulation of protein synthesis, and it's also involved in fetal and childhood growth and development. Calcitonin is involved with decreasing calcium levels, and PTH, also known as parathyroid hormone, is an antagonist to calcitonin, so it increases calcium levels. Types of thyroid cancers. So there are 4 main types of thyroid cancers. The first one is papillary thyroid carcinoma, also known as PTC. This is the most common form of thyroid cancer, and it is also the least aggressive as it grows and metastasizes slowly. The second type is follicular thyroid carcinoma, or FTC, and this specific type of cancer can be associated with iodine deficiency. The third type is medullary thyroid carcinoma, or MTC, and this is a cancer of non-thyroid cells that are found in the thyroid gland, and it is also associated with multiple endocrine neoplasia too. This cancer does produce an excess of calcitonin, which makes it more easier to detect as this serves as a tumor marker. And finally, anaplastic thyroid carcinoma, or ATC, and this is the least common form of thyroid cancer, but is also the most dangerous form because it metastasizes early to the lymph node and other distant sites. Okay, so molecular biology of thyroid cancer. So thyroid cancer can be attributed to genetic mutations. So there are 4 main genetic mutations that contribute to the development of thyroid cancer. This includes BRAF point mutations, RAS point mutations, RET and PTC rearrangements, and PAX8 and PPAR rearrangements. For BRAF point mutations, this triggers signaling. It triggers a signaling pathway, also known as the MAPK pathway, that leads to genetic changes. So the most common form of a genetic change would be a point mutation, and the initiation of this pathway would result in thyroid tumorigenesis, so the generation of a thyroid tumor, and it is most commonly found in PTC. RAS point mutations, so it triggers signaling pathways. It triggers signaling pathways involved with thyroid tumor formation. And there are 3 specific types of RAS genes involved, and the point mutations occur in 3 specific codons, and this then stimulates a constant. It involves a constant stimulation of genes that are controlled by RAS, which then ultimately leads to unstable genome mutations and malignancy, and it's most commonly seen in FTC. For RET and PTC rearrangements, RET becomes activated in follicular cells after a chromosomal rearrangement, and then this genetic mutation is involved in the pathogenesis of childhood PTC and PTC caused by radiation. For PAX8 and PPAR rearrangements, this involves a rearrangement of the PAX8 and PPAR genes. Chromosomal translocation between chromosomes 2 and 3 leads to a PAX8 and PPAR rearrangement, and then this results in the tumor suppressor activity of PPAR to be inhibited, which can result in the generation of thyroid cancer. And this is also more common in FTC. Okay, moving on to diagnosis. So, the diagnostic approaches. Thyroid cancer can be detected in the body through thyroid nodules, which can be benign or malignant. And thyroid nodules are lumps that are either solid or fluid-filled in the thyroid. So some diagnostic tests include serum TSH, nuclear medicine imaging, which can include radioiodine scans, FNA biopsy, also known as FNAB, ultrasounds, and molecular markers. So for the diagnostic tests, the initial diagnostic exam after the discovery of a thyroid nodule would include obtaining a serum TSH level. Okay, and measuring TSH levels to determine malignancy is used because TSH can indicate if a nodule is functional. If the TSH levels are below normal, this would indicate that the thyroid gland is hyperactive, and then a nuclear medicine imaging study would be used. So this nuclear medicine imaging study would indicate if the nodule is hyperfunctioning, isofunctioning, or non-functioning compared to the thyroid tissue. So a functional nodule is a nodule that produces excessive thyroid hormones, and a non-functional nodule is a nodule that produces normal thyroid hormone levels. So for hyperfunctioning and isofunctioning nodules, this would not require any cytologic evaluation except if the patient is symptomatic. But if the nodule is non-functioning, an FNA biopsy would be used for cytologic evaluation. Okay, looking at FNA. So FNA is used for non-functioning nodules with specific features found in ultrasounds. FNA is the most accurate and cost-effective diagnostic method for examining nodules, and there's two ways to perform an FNA, either palpation or ultrasound-guided. So ultrasound-guided is preferred as it reduces the risk of needing a repeat FNA biopsy due to inadequate samples. And if in an FNA biopsy, it obtains at least 6 follicular cell groups that contain around 15 cells from at least 2 different aspects of a nodule, and this will then be used for cytologic examination. Ultrasound. So in addition to the serum TSH test, an ultrasound of the neck would be performed to detect any suspected nodules and analyze them for specific features if any are found. It also determines if a nodule is solid or fluid-filled. So solid nodules are most commonly associated with cancer, and it also identifies the number and size of nodules and any enlarged lymph nodes. Radioiodine scan. So this is used when a patient has a lump in their neck to determine if they have thyroid cancer. It shows if a cancer has spread in patients who already have a differentiated thyroid cancer diagnosis. And with this process of the radioiodine scan, a small amount of radioactive iodine called iodine 131 is consumed or given through IV, and the iodine will be absorbed by the thyroid gland or thyroid cells over time. And then after a couple of hours, a specific and specialized camera will be used to detect where the radioactivity occurs. So areas that have less radioactivity are non-functional nodules, and areas with more radioactivity are functional nodules. It's also important to note that in medullary thyroid carcinoma, or MTC, the cells don't absorb iodine, so it would not be used for this cancer type. And it's also important to note that for CT scans, which is also a common diagnostic test used in cancer, the CT contrast and used before the CT scan contains iodine, and this can affect the radioiodine scan, so in this case MRI would be preferred. These are just some pictures of the radioiodine scan. Okay, molecular markers. So this is related to the molecular biology portion that we mentioned before. So as we know, there are many genetic and molecular alterations that occur with thyroid cancer, with genetic mutations being the most common. So for molecular markers, we would examine molecular markers that are involved in the pathogenesis of thyroid cancer. So this can include genetic testing to identify any mutational markers. We would also identify molecular and genetic alterations, and this is helpful for differential diagnosis of thyroid tumors. So as we mentioned before, specific genetic mutations are associated with a specific type of thyroid cancer, so this can be helpful in determining the diagnosis. Lab values. So for lab values, the thyroid gland usually functions normally in thyroid cancer, so some of the lab values may be the same, or maybe like they will still be in the within the normal range. So for blood tests are not used to diagnose thyroid cancers, but they're used to check or assess the hormone levels, which can indicate endocrine function. So for calcitonin, as you mentioned before, it's elevated in MTC. For TSH, it's usually normal in thyroid cancer, but it can be high if the thyroid gland is not producing enough thyroid hormones. And for T3 and T4, it is usually normal in thyroid cancer. Okay, now moving on to staging approaches. So thyroid cancer is diagnosed histologically, so through the examination of thyroid tissue and thyroid cells, and this is examined through the FNA. This is done through the FNA biopsy. And then for the staging approach, we use the TNM staging. So T is for tumor, so characteristics of the tumor, N is for nodes, so lymph node involvements, and M is for metastasis, so if the cancer has spread. Okay, so for the TNM staging of PTC and FTC, so this is used for, this specific one is used for patients that are 45 or older. And then again, for stage 1, it's usually more localized, and then as the stages increase, this cancer spreads, and with stage 4 being the most aggressive, so there is distant metastasis in stage 4. And then for MTC, there is a stage 0, so it's clinically occult. So what that means is that the disease is not accompanied by any detectable signs and symptoms, but it can be detected by biochemical screening. So as you mentioned before, MTC has produces higher calcitonin levels, so then this can be used to detect MTC. And then again with the stages, so in stage 1 is usually localized, and then as the stages go on, the tumor and the cancer starts to spread, with stage 4 being the most aggressive, again with distant metastasis. And then for the TNM staging for ATC, there is no specific staging, as all patients are considered to have stage 4 because, as we mentioned, ATC is the most aggressive form since it's defined by distant metastasis. And then finally, for nursing role, so there are 3 aspects: emotional, physical, and social. So for the emotional aspect, we would make sure to provide compassionate care. We would listen to the patients and being present and understanding. For the physical aspects, we would make sure to conduct the appropriate assessments and to conduct any pain assessments, as the patient may have pain, and so it's important to conduct pain assessments so we can implement any pain interventions. And then for social, we can provide referrals, so for example support groups. We can advocate for the patient and provide adequate patient education so the patient is well informed to make decisions regarding their health.
Now we will examine the different treatment options for our patient. Amy is inquiring about the different treatment options. The healthcare team gives her an overview of the various options. Surgery. Surgical removal is the most common treatment option for thyroid cancer. There are 3 types of surgical procedures used. The first is a lobectomy, which involves the removal of the lobe that contains the cancer. Other surrounding lobes may also be removed and examined for cancerous cells. The second is a near total thyroidectomy, where almost the entire thyroid is removed except a small piece is left behind. The third is a total thyroidectomy, where the entire thyroid is removed. Radiation. Radiation is another treatment option. External radiation and internal radiation can both be used. Radiation may be used in combination with surgery. Radioactive iodine therapy is also an option, which is taken by mouth and to destroy thyroid tissue. Chemotherapy. Chemotherapy is another treatment option. Both systemic and regional chemotherapy can be used depending on the case. Examples of chemotherapy drugs include Caprelza, Lenvima, and Nexavar. Thyroid hormone therapy. Thyroid hormone therapy is another treatment option where the patient takes a drug that prevents thyroid-stimulating hormone from working. Targeted therapy. Targeted therapy is another treatment option. This therapy uses drugs which target and attack specific cancer cells. Tyrosine kinase inhibitor and protein kinase inhibitor are examples of drugs used in this therapy. Immunotherapy. This is a newer treatment option currently being tested in clinical trials. The patient's own immune system is used to target the cancer. The role of the nurse is to ensure the patient has an adequate understanding of each treatment method, including the potential risks and complications. After learning about the different treatment options, our patient chose to opt for a total thyroidectomy, the surgical removal of the entire thyroid gland. Amy asked the nurse what will happen during the surgery. The nurse explains that Amy will go under general anesthesia for the surgery. The surgeon will make an incision on her neck and remove the cancerous tissue and the entire thyroid gland. She will then have stitches and a dressing on her neck. Complications. There are various complications that can arise after the surgical removal of the thyroid gland. The nurse must assess and watch out for the complications. Infection is one complication to look out for. The nurse should assess for signs and symptoms of infection, such as fever, chills, redness, swelling, purulent drainage, and warmth. Another complication that can arise during surgery is injury to the laryngeal nerve, which can result in temporary, or in rare cases permanent, hoarseness of the voice. A serious complication that can occur if the nerve is damaged is aspiration. Injury to the esophagus or trachea can also occur during surgery. The patient may experience difficulty swallowing after the surgery. A life-threatening complication that can occur is hemorrhage after the surgery, which can cause compression of the airway. Another possible complication is hypoparathyroidism. Hypoparathyroidism can occur if the parathyroid gland is damaged and affected during surgery, which results in hypocalcemia. Recovery after the surgery. The nurse should provide health teaching to the patient here after she asks what will happen after the surgery and when can I go home. The nurse can inform the patient that most patients are able to go home the same day after the surgery or a few days after. The patient should limit intense physical activity for a few weeks after the surgery to prevent any complications. The nurse and patient should assess the incision site regularly for signs of infection. The nurse should educate the patient about thyroid hormone replacement drugs. After a total thyroidectomy, there will be a lack of thyroid hormone as the body no longer has this gland. For the rest of the patient's life, they will need to take thyroid hormone replacement drugs to make up for this loss. Now we will look at an oncologic emergency in the context of this patient. An oncologic emergency that can occur in thyroid cancer is airway obstruction by the cancerous growth. The cancer can invade the trachea or compress the airway, causing obstruction which can become emergent if the patient's ability to breathe is obstructed. Signs and symptoms of an impaired airflow can include dyspnea, coughing, a loss of consciousness, an alteration in voice or speech, confusion or agitation, dizziness, labored breathing patterns, and cyanosis. The nurse must watch for these signs and symptoms of impaired airflow. Removal of the obstruction by surgery is the most effective method in correcting this emergency.
As we've been learning in class, we know that the impact of cancer diagnosis does vary amongst different individuals and different types of cancers, but is nonetheless profound in every aspect of the human experience. And starting off with the physical impact of Amy's diagnosis and treatment, we know that from the initial admission, she did present with significant swelling in her neck, which her son actually had to point out. And this is actually a common symptom of FTC, follicular thyroid carcinoma, called goiter. It's basically the enlargement of the thyroid gland, but it isn't always a telltale sign of thyroid cancer. It could also be present in other diseases such as hyperthyroidism and hypothyroidism. But in Amy's case, her goiter is related to her cancer diagnosis, and it's gotten to the point where the swelling has caused dyspnea, dysphagia, and hoarseness, but no neck pain. And at this point, we know that the thyroid has grown to a size that's causing compression onto the nearby airways, affecting breathing, speech, and swallowing. As for systemic effects, she has experienced unintended weight loss, fatigue, as well as nausea and vomiting, which we do know are common side effects seen in individuals with cancer, whether that be a result of chemo medications, treatments, or the actual tumor affecting surrounding organs, tissues, and so on. And so weight loss associated with thyroid cancer could be attributed to the thyroid's inability to regulate hormones. Hormones such as T3, T4, and insulin are essential hormones that mediate different aspects of the body's metabolism. Hence why individuals like Amy would experience fluctuations in their weight. Unexpected weight loss and fatigue may also be indicative of the extent of the disease progression as well as a possibility of metastasis. And following her surgery, Amy did present with expected outcomes of a thyroidectomy such as neck pain, discomfort, swelling, bruising, and so on. Her postoperative nurse actually did observe a temporary voice change, but it did resolve after 48 hours. Prior to her diagnosis, Amy's son did show great concern for his mother's mental health and actually stated that he missed the way his mother used to be, speculating that his mother was dealing with depression. He described his mother to be an outgoing and very social individual who always hosted dinner parties to celebrate his accomplishments, no matter how insignificant it was to him. She had gone through several depressive episodes ever since and is still struggling with depression to this day. Amy says she hasn't had the energy to take on any household chores or any self-care tasks, so her son has had to step in to help her out on the weekends when he can. During his visits, he did notice that she's been spending a lot of time in her late husband's old office at night and has rarely gotten any sleep the days preceding her surgery. But thankfully, her insomnia did improve after her procedure, but she does spend a lot of time worrying about her recovery and whether or not life will go back to quote-unquote normal. And just like in any other cancer diagnosis, there's bound to be fear and anxiety even after a patient has gone through treatment. And even with the help of top-notch physicians, there will always be that uncertainty surrounding prognosis and the recovery process. As for body image, Amy did express that she was insecure about her goiter being visible. She says that she would rarely put her hair up and tried to wear scarves whenever she could to try to hide the swelling of her neck. And now, given her new surgical scar from her procedure, she does remain self-conscious about revealing her neck in public spaces. And Amy's son actually believes that this may be the reason that she's been isolating herself and not attending family events as she usually would. And this may be true, but this could be a result of not one, but multiple psychological factors revolving her diagnosis. Now, we're beginning to see that these psychological experiences do in fact bleed into an individual's social life and relationships. Amy has been withdrawn from social events and with family, and her efforts to isolate herself from her social circle may be a result of several factors, such as possible feelings of guilt towards her son for taking on a huge role in her care, stigma surrounding cancer, or even fear of how her family and friends might react or even treat her knowing her situation. Even her culture could heighten the emotional strain in her relationships. Engaging in open and honest dialogue can be taboo in her culture, especially regarding mental health. And these ineffective coping strategies may possibly worsen her psychological and emotional symptoms, ultimately leading to a cycle of mental deterioration, impacting her recovery process overall. She's also expressed that she isn't ready to go back to work just yet, as she can barely tolerate household chores, and at the moment isn't ready for everyone to quote-unquote see her like this. Her son also admits that she's been denying any visits from her coworkers that just want to check up on her. Her son has had to help financially given this situation just to afford her treatments and medications, which only intensifies the caregiver workload. However, the interprofessional team has been very helpful in providing Amy and her family with coping resources such as cancer support groups. And although hesitant at first, she's been attending these meetings consistently and has found a new friend named Sam who does share the same diagnosis as her. Her son, on the other hand, has been open to attending therapy sessions and is currently finding the time to do so given his busy schedule. With further insight into the lives of people like Amy, we can see that cancer's impact extends far beyond the physical aspect. It carries into emotions, relationships, and self-perception. Amy's journey, although marked by hardships and struggles, it does exhibit the resilience and the strength of all the families affected by cancer. The fear, the anxiety, the shifts in social interactions, and the altered self-image, all these elements resonate in the silent battles fought beyond medical procedures. And as we continue to research the complexities of cancer's reach, it also emphasizes the importance of holistic support, understanding, and empathy in fostering resilience and recovery.